Welcome to our presentation on thrombotic microangiopathy syndromes, presented by Dr. Wadin Jarullah and Ahmed Solomon. We will explore the complexities of these syndromes, including their classification, pathogenesis, and treatment approaches. Our presentation will cover 6 key areas: introduction, classification, pathogenesis, diagnostic approach, therapeutic approach, and prognosis. Each section will provide a comprehensive understanding of thrombotic microangiopathy syndromes. Let's begin with the introduction. Thrombotic microangiopathy, TMA, involves small blood vessel damage leading to platelet aggregation and thrombocytopenia. This can result in mechanical injury to red blood cells. TMA includes conditions like hemolytic uremic syndrome, HUS, and thrombotic thrombocytopenic purpura, TT. Other related conditions include disseminated intravascular coagulation, DSC, and malignant hypertension. Next, we will discuss the classification of TMA. Understanding the different types is crucial for accurate diagnosis and treatment. TMA can be classified etiologically into inherited and acquired forms. Inherited forms include HUS due to complement mutations, while acquired forms involve antibodies to complement proteins. STCHUS, caused by Shiga toxin-producing E. coli, accounts for over 90% of HUS cases. It is often associated with specific serotypes like O157, A7, and can occur in epidemics. Now let's explore the pathogenesis of TMA. Understanding the underlying mechanisms is essential for developing effective treatments. In HUS, the alternative complement pathway, ACP, is activated, leading to endothelial cell injury. Dysregulation of ACP can result from genetic or acquired defects, triggering TMA. TTP pathophysiology involves the lack of ADAMTS13 protease, leading to the accumulation of large von Willebrand factor multimers, causing platelet aggregation and TMA, primarily affecting the CNS. Next, we will discuss the diagnostic approach. Accurate diagnosis is critical for effective management of TMA. The diagnostic approach involves a 3-step process: diagnosing TMA and HUS, differentiating infection-induced causes, and excluding TTP while investigating other causes of HUS. Step 1 involves clinical and laboratory evaluation. Clinical signs include renal and non-renal symptoms, while laboratory tests focus on hemolytic anemia and thrombocytopenia. Microscopic examination of blood smears can reveal schistocytes, which are indicative of microangiopathic hemolytic anemia, a key feature of TMA. Step 2 focuses on differentiating infection-induced HUS. Shiga toxin-associated HUS should be suspected in children with recent bloody diarrhea or those from endemic regions. Streptococcus pneumoniae-associated HUS is generally seen in infants and toddlers. It often follows invasive infections like pneumonia or meningitis. Primary atypical HUS should be suspected in cases without recent diarrhea or with specific clinical features like insidious onset or family history of HUS. Step 3 involves excluding TTP and investigating other causes of HUS. This includes testing for ADAMTS13 deficiency and complement regulation disorders. Now, let's explore therapeutic approaches. Treatment strategies vary based on the type and severity of TMA. Therapeutic approaches include supportive therapy, plasma therapy, and C5 inhibitors. Supportive therapy is essential in all types, especially in typical HUS. Supportive therapy includes fluid management, blood transfusions, and antibiotics. Platelet transfusions are generally avoided unless clinically necessary. Dialysis may be required in cases of symptomatic uremia or refractory fluid overload. Nutritional support is also important in managing oliguric HUS. Plasma therapy, including plasma infusion and exchange, is crucial for complement-mediated HUS. It helps replace deficient components and remove harmful antibodies. C5 inhibitors like eculizumab block complement activation and are effective in treating complement-mediated HUS. They significantly improve platelet counts and kidney function. Ravulizumab, a newer C5 inhibitor, offers sustained inhibition with less frequent dosing. It is approved for pediatric use in atypical HUS, providing a cost-effective alternative. Finally, let's discuss prognosis and transplant considerations. Prognosis varies based on the type of HUS and available treatments. Typical HUS has a favorable prognosis, but atypical HUS, especially before eculizumab, has a poorer outlook. Transplantation may be necessary in severe cases. Here are the references used in this presentation. They provide a comprehensive overview of the current research and clinical guidelines on TMA. Additional references are provided for further reading. These sources offer in-depth insights into the management and treatment of thrombotic microangiopathy syndromes.